Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host for tonight's program on lung problems. We'll be glad to take your questions on conditions like pneumonia, influenza, emphysema, COPD, and cancer. The success of this program is very dependent on you, the viewer, so please call in your questions and we will do our best to address them. The telephone number for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Mary Boylan, a cardiothoracic surgeon with St. Luke's Cardiothoracic Surgery Associates, Dr. Wayne Elmer, a pulmonary medicine specialist with St. Luke's Pulmonary Medicine Associates, and Dr. Jake Powell, an internal medicine specialist with St. Luke's Internal Medicine Associates. Our telephone volunteers answering the phones tonight are Mindy Cavall-Anderson, a first-year medical student from Wilmer, Minnesota, and our medical school staff include Cheryl Pearson and Linda Liskowitz. And now on to tonight's program on lung problems. So we thought we would start with some models tonight. Dr. Boylan, you brought in some lung model and maybe explained the anatomical structures of the lung.
Sure, absolutely.
Can I hold it for you?
Oh, thank you. Absolutely. So this is a model, kind of a cartoon demonstration of what the lungs look like. So in my specialty, cardiothoracic surgery, we deal with the lungs, the heart, and all the structures that are in the chest. When patients come in, a lot of patients really don't have a real good understanding of how the lungs work. People who are hunters, who dress out their deer, they kind of know, but a lot of people don't. So in the human being, the way we're designed is that we have 3 lobes on the right. So on the right, so this is the right side of the body, this is the left side, just like Dr. Elmer's right side and left side. There's an upper lobe, a middle lobe, and the lower lobe. Lower lobe kind of sits behind the other two. On the left side, there's an upper lobe and a lower lobe. Now, we have the luxury of pulling off the upper lobe here, and we kind of take a look on the inside. So when we think about anatomy, and anatomy really is key in our being able to diagnose lung problems and also knowing how to treat them. We swallow, we breathe air through our nose or through our mouth. It goes into the windpipe. We can all feel our windpipe here. That's those little rigid rings that we feel. Comes down, the windpipe then splits here and sends pipes to each the left and the right side. And this demonstrates the windpipes as they keep branching out further and smaller into the very far parts of the lung. The blood vessels arise from the heart and drain back to the heart. So this central part of the chest is a very, very busy intersection. There's windpipe, there's blood vessels, arteries, veins, everything goes through there. So that impacts how we can diagnose, how Dr. Elmer will diagnose diseases, things that Dr. Powell will see on chest x-rays, and then how we treat them surgically. So that's kind of a very, very brief little elementary overview. Heart obviously sits in the middle, and we can look at this a little bit more later on.
Very, very helpful. Well, let's talk about a few terms too while we're waiting for a couple questions. Dr. Elmer, COPD is one term we hear a lot. Can you explain what that is?
Sure. COPD stands for chronic obstructive pulmonary disease. And you hear a lot about COPD because it's one of the most common types of lung disease that we deal with on a regular basis. In fact, COPD is the 4th leading cause of death in the United States and globally. And COPD is sort of an umbrella term. Underneath the umbrella of COPD, there's more specific diagnoses such as chronic bronchitis or emphysema and bronchiectasis. We tend to lump them together because in many respects we treat them very similarly. The diagnoses differ based on the types of symptoms that patients have, and the treatment may vary somewhat between the different diagnoses, but generally speaking, they're often treated similarly.
Go ahead, Dr. Boylan.
I was just going to say, I know that one thing we all see all the time is that when we talk about diseases here, we just talk about COPD, but rarely do patients come with just one diagnosis. And that might just be a tag on to their acute event, whatever that happens to be, that brings them to the hospital.
And there's a huge overlap between heart and lung disease, and this is one of the reasons why we overlap pretty heavily with Dr. Boylan's specialty, cardiothoracic surgery of the heart and lungs. I think one of the things I feel obligated to talk about when we talk about COPD is the fact that probably 85 to 90% of people that have COPD get it from smoking. Smoking is by far the most common cause of COPD. It's not the only cause, but it's certainly the most common one. If people didn't smoke, COPD probably wouldn't figure that prominently in our practice. But it's a fact of life. A lot of people smoke. The prevalence of smoking in the state of Minnesota is about 17%, and it imposes a significant burden of disease on the population.
We need to have everyone quit. That would be wonderful, but hopefully in the future.
Sure.
Well, Dr. Powell, a question has already come in about influenza. And if you can describe symptoms of influenza and the things that we can do to avoid getting influenza.
Well, we had a really brisk and early influenza season this year, and anyone who had it knows the main symptoms are fever, body aches, sore throat, headache occasionally, cough commonly. Those symptoms are typically very quick onset, very intense. People who are vaccinated this year, there was some people, or some folks who did get the vaccine who got influenza. Their symptoms were typically less severe. If you do feel those symptoms, the flu is still around. We're still seeing cases. Call your doctor right away. There is treatment for it that helps to some degree. It's not perfect, but certainly if you let your doctor know right away, the medication is helpful.
And it's not too late to get an influenza vaccination.
Absolutely. Yeah, that's the key. Vaccines are, even though the vaccine this year wasn't necessarily perfect, it was a pretty good match and it made a huge difference.
We saw a lot of influenza in the hospital, and the majority of the people that I personally was involved with in taking care of that had influenza were not vaccinated. We did have some folks that did get influenza who did also get the vaccine, but they were the minority.
And they were typically less sick than those who did not.
And it doesn't matter what age, any young child on up should get the vaccine, because some of the worst cases that we've seen have been in young people, 39 years old, getting in the ICU with being under the care of our intensivists.
And the myth that you get, the one thing I hear from patients that is a complete myth is they feel that they've gotten the flu from the flu shot in the past. That's just simply not possible. And it's a dead vaccine, and you do not get the flu from the flu shot.
And I can personally testify that I have actually yet to ever take care of someone who is in the hospital because of complications of getting the flu shot.
Extremely unlikely.
Right. But I've taken care of plenty of people who have gotten sick because they didn't get it.
Well, I have a caller asking, continuing with flu, Dr. Elmer, after flu symptoms, have a harsh cough, and then when to return to work after that, or what's causing this harsh cough?
Yeah, influenza, one of the reasons why it's such a virulent disease is it causes something we call a necrotizing tracheobronchitis. What does that mean? Tracheobronchitis means inflammation of the trachea, which is the conducting part of the airway. That's the main windpipe that gets the air down into the lungs. And then bronchitis refers to inflammation of the bronchial tubes, which are the windpipes that carry the air out to the air sacs in the peripheral parts of the lung where the gas exchange actually takes place. And what happens is the inflammation can be so intense that it actually can cause sloughing of the mucosa or the lining of the bronchi. Also, the inflammation switches the mucus glands that line the windpipes into overdrive. And so they're pumping out lots of mucus. So the inflammation in the mucus triggers the cough reflex. And so that's why a typical part of an influenza infection is a pretty vigorous cough that's oftentimes productive of phlegm. Usually, within a week or 10 days or so after the onset of symptoms, you're probably not infectious. But because it is such a contagious disease, we urge people to err on the side of caution if you're sick, especially if you're in a position where you're in contact with other members of the public or people that might be more susceptible to severe illness, the very young or the old, or people with other chronic lung diseases. Probably the wise course of action is to delay your return to work until you feel well.
Dr. Powell, reactive airway disease, caller from Virginia. Would like you to just talk about reactive airway disease?
Sure, that's a sort of a synonym for asthma. It's a condition where typically people will have either allergic reaction or to an allergen or potentially something in the environment like cold. Exercise can trigger it. And kind of to put it in simple terms, it's where the airways constrict, they can increase mucus production, and it falls into the kind of the asthma spectrum, but it's a term we'll use sometimes as a synonym for asthma.
Dr. Boylan, symptoms that patients should be concerned about if, like we're worried about a cancer, how would they present?
Well, one of the challenging things with lung cancer is that so often it doesn't get identified and recognized until it's advanced stage. And a large part of that is because a tumor can grow out in the further part. I always call it the out in the back 40, out in the far part of the lung, and the tumor can grow and grow, but it's not in close to any of the major blood vessels or any of the major airways, so there won't be a lot in the way of symptoms. Very typical, in fact, working with Dr. Elmer and his colleagues, that's how we identify patients with lung cancer. And a very typical story is that a person will present to their physician or to the emergency room with what seems like a pneumonia. And an x-ray is done, and it looks like a pneumonia. On the follow-up x-ray, the spot hasn't gone away. And that kind of gets the ball rolling to then get an evaluation with pulmonary medicine, with myself, my colleague, and then we go down the path of evaluating for lung cancer. Sometimes, so the ones that don't have symptoms are probably the ones that are most treatable. The ones who present with real symptoms of coughing up blood, a real bothersome cough, that's generally because the lesion or the mass is closer in by an airway and causing those symptoms. Infrequently, patients will show up because they have chest wall or rib pain, but that's unusual too. So when we see patients out of the whole spectrum of patients who have lung cancer, a lot of them end up being managed by pulmonary and diagnosed and then go on to oncology management. It's really just a smaller subset who we identify with early stage lung cancer. And lung cancer is such a broad topic, and I think just a few things. We were talking about myths earlier. One myth that I hear often from patients when I see a patient who is a candidate for a lung cancer operation to cut out the cancer, I've been asked many times, well, but doctor, when you do that operation and you expose it to air, isn't that going to make the cancer spread like wildfire through my body? And that really simply is not true. Doing an operation does not cause a cancer to spread, but that's a myth that has been out there and still circulating very strongly, and I'm sure you've heard that too.
I like to remind those patients, you know, that tumor is in the middle of your lung. It's surrounded by air all the time, you know, so I think where that perspective comes from is that oftentimes when we diagnose these cancers, it's already at an advanced stage. And so people get the impression, well, you know, they were just diagnosed and, you know, and pretty soon the cancer was all over the place. And the sad fact of the matter is that the cancer was probably widely spread when it was first diagnosed. Just to loop back to something Dr. Boylan was talking about, one of the reasons why oftentimes people that have a lung cancer in their lung don't have symptoms is because the nerve endings on the inside of the lungs don't sense pain. The nerve endings trigger the cough reflex, but unless the tumor actually involves the lining on the outside of the lung called the pleura, you can have a tumor the size of a golf ball sitting in the middle of your lung. You'll never know that it's there. It won't make you cough. It doesn't cause pain. And oftentimes, in fact, the most typical way that they're discovered is incidentally. When you're not even necessarily looking for a lung cancer, someone gets a chest x-ray for some unrelated reason, maybe a physical, maybe they fall and hurt their chest and, you know, they think they have a broken rib, and then you do a chest x-ray and good grief, what's this, you know, there's a mass in the lung. So that's one of the reasons why lung cancers tend, unfortunately, to be diagnosed at a more advanced stage, because when they're at an early stage, they typically don't cause a lot of symptoms. And by the time they do cause symptoms, oftentimes we've missed the best chance to send them to see Dr. Boylan and have it surgically removed, which is certainly the best opportunity for cure.
Excellent, very helpful. Well, I have a caller from Carlton, Dr. Powell, asking about walking pneumonia, or probably community-acquired pneumonia, as compared to regular pneumonia. Maybe a little help from that one.
So walking pneumonia is a term that I'll hear used to describe different things. In the medical world, when I went to medical school, walking pneumonia was a term they used to describe typically a specific pathogen, a specific type of bacteria. Most of the time what people are referring to when they say walking pneumonia is pneumonia that's not necessarily terribly so severe that they needed to be hospitalized, but is typically caused by a bacteria. It's treatable with antibiotics. It's typically a more mild form of pneumonia is what most people mean. There are certainly other forms of pneumonia that don't necessarily necessitate the patient to be hospitalized, but typically the more severe pneumonias are caused by different organisms than what most people think of as walking pneumonia.
Mm-hmm. Well, Dr. Elmer, a caller from Duluth, a 61-year-old, doesn't smoke, 20 pounds overweight, shortness of breath. Mm-hmm. How come?
Well, there's a lot of reasons why people can be short of breath with exertion. I guess I like to describe it to them as decreased exercise tolerance. Most people breathe comfortably when they're sitting in the chair. They don't notice a shortness of breath until they're going up a flight of stairs or mowing the yard or shoveling snow. And so when we approach it from that respect, when we're looking at exercise tolerance, there's your lungs, there's your heart, there's your muscles. So people can have lung disease that certainly cause them to get short of breath. People can have heart disease that cause them to get shortness of breath with exertion. People can have perfect heart and perfect lungs, and if they spend most of their time sitting in a chair watching TV, they may go out to shovel the sidewalk and they get pretty short of breath. So fortunately, we have some very good evaluations to help us figure out, what's the source of their shortness of breath. And usually we kind of approach it, or at least I personally approach it from the heart, lungs, and then muscles, because if someone has heart disease, we'd probably rather figure that out first, because if we rule out heart disease and lung disease, I'm going to tell them that they should probably exercise more, but before I can tell that to them in good conscience, I want to make sure their heart's ready for the exercise. So someone who does get short of breath, we take a history, identify risk factors for heart disease. If they're an appropriate candidate, we would do a stress test of some variety, and there's a lot of different types of stress tests to make sure that there's no evidence of blockage in the coronary artery. We can do a lung evaluation, which typically involves a chest x-ray and probably something called a pulmonary function test, which is basically we measure how the lungs work, how well they move air in and out of their lungs, measure the size of their lungs, how well the lungs absorb oxygen. And then if the lungs check out okay, then we're kind of, by excluding the other causes, we can focus on maybe the fact that they're less fit than they used to be. That's actually the best diagnosis because that's the easiest one to treat.
Dr. Powell, a caller asking about pulmonary hypertension. This is a caller from Duluth and how it's treated.
Sure. Well, that may be a question better suited for Dr. Elmer, but basically a simple explanation is when most people think of hypertension, they think of what we call systemic hypertension or hypertension in the kind of the rest of the body, your arms, legs, your blood that's going away from your heart. Pulmonary hypertension is hypertension in the pulmonary system. And that can be caused by a whole host of things, sleep apnea. There's idiopathic pulmonary hypertension. It is a cause of shortness of breath, definitely. It's not a common one, but maybe Dr. Elmer wants to expand on that a little bit.
Yeah, no, that's a great introduction. And we probably, as a specialty, we probably wind up managing most of those patients. It's potentially a devastating disease for a couple of reasons, but probably the primary one is it's not necessarily easy to treat. As Dr. Powell mentioned earlier, there are quite a variety of causes for pulmonary hypertension. Sleep apnea is one of the more common ones that people think of, but actually it has to be really profoundly severe sleep apnea to result in pulmonary hypertension. COPD is actually another disease. Any disease that causes your oxygen level to be low, a low oxygen level can contribute to pulmonary hypertension over time. The reason why pulmonary hypertension can be such a devastating disease is that it can cause the right side of the heart to fail. And once that happens, once that's far down the tracks, it's not easy to reverse, and it can be really a disabling disease. So the goal with pulmonary hypertension is to diagnose it early if possible. Shortness of breath is probably the primary symptom. Unfortunately, it's a very nonspecific symptom because there's a lot of things that can make you short of breath. But we have a pretty good test to figure out if they have pulmonary hypertension. It's called an echocardiogram. It's a non-invasive test, and it's pretty reliable and accurate. And once we establish that it's there, then it's a much more comprehensive evaluation to identify the cause of the pulmonary hypertension, because the cause is really going to dictate what the treatment is.
Sometimes patients end up needing heart surgery if they have pulmonary hypertension and valvular heart disease. And echocardiograms are great tests. They're not painful. Some gel is put on the chest, and then an ultrasound probe is used, and we get just a whole lot of very valuable information. We can measure pressures in the heart. We can look at the anatomy of the heart, the function of the heart, and that's one of the steps in clearing someone to then go on to decide,
Right.
whether they can exercise or
An
not.
echocardiogram is frequently part of a workup for shortness of breath. And so it's a great topic.
Very great. Yeah, there's lots to say, isn't there? I mean, it's just so many good points. Dr. Paul, a caller asking about, you have a fractured rib and it's hard to breathe. How long does that take to heal? Why is it so difficult to breathe?
Well, and I'll absolutely let Dr. Boylan talk after I do, but we see this time of year, especially with icy sidewalks and streets. In fact, I've had several of my own patients fracture ribs. And typically, it's very painful. Typically, it doesn't require the patient to be hospitalized. It typically doesn't require any type of surgical intervention. You usually just let it heal on its own. It can hurt for 2 weeks. It can hurt for 8 weeks. We do an x-ray of the chest to make sure that the lungs haven't collapsed, make sure the rib isn't displaced, make sure there's no sign of bleeding in the chest. If there is, they go see Dr. Boylan. But usually they're managed conservatively. Healthy people typically recover in a few weeks.
And people can get really sick from broken ribs. I mean, if they fracture multiple ribs, they can be stuck in the ICU on a breathing machine because it hurts too much to breathe. And if one of the blood vessels, every rib has a blood vessel under that, if that blood vessel breaks or tears, they can bleed inside their chest. So most people, fortunately, don't have severe multiple rib fractures and can be treated as outpatients, but that's one of the things that we find ourselves operating on when people have complications from multiple rib fractures.
Dr. Elmer, a caller asking about pleurisy and from Superior, what causes it?
Yeah. Remember I referred earlier to the fact that the lungs, the nerve endings on the inside of the lungs aren't capable of sensing pain, but there's a lining on the outside of the lung. You can't see it on the model here, but if you could imagine if we took like saran wrap and just sort of wrapped it on the outside of the lung, except it's just incredibly thin, just literally a few cells thick. The pleura, unfortunately, has a very rich supply of nerve endings that can sense pain. And so anything that causes inflammation or any trauma that penetrates the pleura, like a broken rib, can cause intense pain. And pleurisy is a very distinctive type of pain because it tends to be very focal. It's like you can identify it hurts right here. And people will often describe it as like an ice pick in the ribs. The most common cause of pleurisy is probably just localized inflammation, maybe from a virus or something. It's typically treated with over-the-counter anti-inflammatory medications like ibuprofen. Pleurisy can be part of a syndrome of a different disease like influenza. People can get pleuritic chest pain. So,
well, Dr. Boylan, I know you have one other prompt out here that you might want to show regarding lung surgery and some.
So when we do the history of lung surgery, is that the usual approach to lung surgery has always been an operation where you go between the ribs and then spread the ribs to be able to get inside to the lung. And that's the way we've done lung surgery forever. In the past 20 years or so, with technology coming along and all kinds of instruments coming along, we do things smaller. People don't get their gallbladders taken out through big 6-inch incisions under the ribs. They get it done through a scope. Hernias get fixed through little incisions. Everyone gets laparoscopies. People get their knees scoped, their shoulders scoped. We also do scopes for the lung. And when we do that, we can't put your whole hand in between the ribs, so we have instruments. And I always kind of think of it as like eating Chinese food, where you use sticks to reach at things. And one of the standard instruments we use when we operate on lungs through small incisions, and truly the incisions are this small, just big enough to let this in. This is a type of a stapling device. So when we're going to resect or cut part of the lung, we just put this on like a scissors and can apply it, and it cuts and staples. And we can do all these operations through small incisions. And in fact, our standard approach is really to do all lung surgery through small incisions, including taking out an entire lobe through a small incision. Now, not all patients are candidates for that, but that certainly is the approach. And it's night and day difference for patients who don't have to have that big incision where we spread the ribs. They get up, they feel better, they move more quickly.
Well, thank you. We had multiple questions. I'm sorry we couldn't get to many of them tonight. I want to thank our panelists, Dr. Mary Boylan, Dr. Wayne Elmer, and Dr. Jake Powell, and our telephone volunteers, Mindy Cavall-Anderson, Cheryl Pearson, and Linda Liskowitz. Please join Dr. Ray Christensen next week for the last program of the season on high blood pressure, when his panelists will be Dr. Ryan Harden, Dr. Dave Hutchinson, and Dr. Mike Swanowski. Dr. Swanowski is a pharmacist with the College of Pharmacy. Thank you for watching, and happy Valentine's Day.